Thank you very much, Anil, for that kind introduction. Thank you, Radha, for inviting me to speak on Foundation Day. Really very proud to see two of my previous fellows on the panel, JP, who has just spoken, and Ashwani Singhal. Also happy to see Paul Thulaworth. Both of us went to medical college at St. John's many, many years ago. Happy to see that he's also on this panel. So let's take a patient that we typically will come up with. So this is a patient, 47-year-old male with alcohol-associated hepatitis. Exam shows ascites, but no encephalopathy. Total bilirubin 3.5, INR 2.1, and creatinine 2. So the question we have here is, how do we determine this patient's risk of death? So for me, the first examination always starts at the bedside. If there's no encephalopathy and no ascites, I know generally this patient is going to do very well. On the other hand, if I see either ascites or encephalopathy, or especially if I see both, then I need to go to some scoring system to find out what is the risk of mortality in this patient. So an ideal prognostic model for alcohol-associated hepatitis should use easily available variables. It should be prognostic across all stages of disease, mild, moderate, and severe. It should classify disease according to severity. It should be useful in determining treatment benefit and futility. And it should be applicable to other etiologies of liver disease. Remember, there is one allocation system for organ transplantation in most parts of the world. So you cannot have a different score for each disease. And the question I have to address is MELD score this ideal model? So in this talk, I will go over the determinants of mortality in severe AH, MELD and mortality, MELD versus MADRI and other models, MELD for treatment benefit or for futility, future directions, and then maybe we'll have some take-home messages. So the determinants of mortality in severe AH are really based on the pathophysiology. Patients with severe AH get an inflammatory response, they get infected, which worsens the inflammatory response, and then they get organ failure. And in the absence of effective treatment or liver transplantation, these patients will die. So when we are treating these patients, the potential therapeutic targets are as follows. So the patient started with compensated liver disease. Following alcohol use, developed alcohol-associated hepatitis. Then that patient got infected. So our treatment is going to be treatment of the alcohol-associated hepatitis, infection, organ support, and in selected patients, liver transplantation, and that will get the patient back to compensated liver disease. So really the determinants of mortality in severe AH are not just the severity of liver damage, it's also the degree of inflammatory response, type and severity of infection, number of organ failures, and the availability of effective treatment, and all these will impact survival. So let's come to MELD and mortality in AH. Traditionally, we've used the MADRI discriminant function. It is extensively validated. DF greater than 32 presents 50% mortality, calculated as 4.6 times prothrombin minus control plus bilirubin, and this calculation is important, we'll find out later. It is derived for steroid treatment. The problem is that patients can have a DF less than 32, and they still have a significant risk of death, and we typically do not capture it when we use this score. The MELD score is more generalizable than the prothrombin time. There are easily available calculators for this, and the cutoff can be based on side effects of treatment. In general, good rule of thumb to remember is MELD score of 20, approximately 20% probability of 90-day mortality. And from different studies, the 90-day mortality with MELD of 20 has ranged between 15 and 22%. So in our particular patient with the bilirubin of 3.5, INR of 2.1, and creatinine of 2, this patient's MELD score is 26, which will contribute to mortality of 47% in 90 days. So we can use this nomogram to decide mortality at different time points. So we can have mortality at very low scores and at very high scores. And this is the advantage of the MELD score over MADRI and other scores. So let's compare MELD versus MADRI and other models. So the first concern about MADRI came from this paper. It's a retrospective study, 41 patients, DF greater than 32, 39% died, but 48% DF less than 32, 16.7% died. So there's still substantial mortality. Additional problem is INR is usually more universal and can be applicable across, but prothrombin time has many problems, which we may discuss a little later. And the MDF uses the prothrombin time. Still not clear what you should use as the control when they give you a range of controls. And the decision for therapy is influenced by the side effect of intervention. A high mortality was taken for the MADRI score just because of steroids were used and the side effects. But maybe if you're using safer drugs, then we don't need this high cutoff. So this study about 8 years ago compared MELD versus other predictive models. Let's just focus on 30-day mortality and 90-day mortality and the area under the curve. So you can see here, area under the curve for 30 days, MELD was better than discriminant function, and also again for 90 days. But perhaps a better study is the one with JP and Ramon Botaya put together. And this is the reference and it's available online. It's a global study looking at more than 3,000 patients comparing MELD versus MDF. The title of the paper is MELD score is superior to the MADRI DF in alcohol-associated hepatitis, a global study. And the conclusion was that MDF should no longer be used to assess AH prognosis, and the MELD score is the best for predicting short-term mortality. And here are the data from the study. Again, my thanks to JP for allowing me to use this slide. So these are the different colors telling you the scores. ABIC, that's AH, bilirubin, INR, creatinine, Glasgow score, MDF, MELD sodium, and MELD. The area under the curve, and the p-values when you compare across scores. So MELD and MELD sodium, no difference. MELD better than MDF, better than Glasgow score, and close to significant, but not statistically significant, better than the ABIC. So here, MELD came out better, and you can see if you read this paper that MDF really was the least sensitive of all. If you look at 90-day mortality, again, the same findings, same color scheme. MELD and MELD sodium about the same, better than MDF, better than Glasgow score, but close to significant, but not significant, and ABIC. So based on this, MELD score is better for 28 and 90-day mortality than other models. Now this paper from Alex Louvet looks at combining MELD score with the allele score. So here's a patient with MELD score 21. 7 days later, the allele score is 0.45. You can use this to determine 2-month mortality, which in this patient is 15%, and 6-month mortality, which is 24%. So to summarize, to determine severity of AAH, at admission, it is the MELD score. During treatment, the allele score, and long-term combined MELD and allele score. Also very important is whether abstinence occurs or not. We can also use MELD score for study stratification. So currently, mild AH is low mortality, so 10 or less MELD score. Moderate is intermediate, 11 to 20, and severe is high mortality, that's greater than 20, which means 21 or greater. And so patients with low and maybe even intermediate mortality should be excluded from studies where you use mortality as endpoint. And there are multiple studies which have shown that MELD greater than 20, which is really 21 or more, is the optimal cut point for mortality. Now, what about if you're studying a new drug? Because these are small number of patients, so you cannot use mortality as an endpoint. So let's look at the MELD score. MELD score of 20 is a 20% mortality. 15 is a 13% mortality. MELD of 28 is a 54% mortality. And MELD of 23 is a 35% mortality. So I've taken a decrease of 5 from each score. So let's take moderate AH. So score is 20. A decrease by 5 is a 7% decrease in absolute mortality or a 30% decrease in relative mortality. Similarly, severe AH, a decrease by 5. So here is a 19% decrease in absolute mortality or a 30% decrease in relative mortality. So that is why the current recommendation is a MELD decrease by 5 may be used as an endpoint for pilot studies investigating benefit of new drugs. Finally, what about treatment benefit using MELD or futility? And this again, I have to thank JP for this global study where they address the question of whether there's a therapeutic window of MELD score for the use of corticosteroids, 3,380 patients. The circles are mortality following steroid treatment, the squares in the control group. And the difference is the difference in mortality. So you can see the largest difference, which is highly effective, which is greater than 20% reduction, is in the dark blue. So in this study, they confirmed the benefit of steroids in MELD score greater than 20. And the reduction in mortality was at 30 days, but not beyond that. And the greatest benefit in mortality was between 25 and 39. And no matter how high the MELD score was, treatment was effective. The STOPA study, which was a prospective study, suggests that the best treatment, the best benefit is between 20 and 28, and beyond 35, they did not see the benefit. So we're not certain at this time about futility. What about future directions? And we've had some discussion following the last talk on this. Should we add to the MELD score inflammatory markers, regeneration markers, other biomarkers predictive of reversibility, organ failure scores, or histology? But note of caution here. Remember, addition of variables can add complexity and limit applications. You add biopsy and you don't do it on most, that model is not good. So always balance predictive accuracy and ease of implementation. The fewer the variables, and if you use the variables on a regular basis, can be widely applicable. Organ failure models are reflective of the dying process. They're not predictive of mortality. They may be used to exclude patients from studies, may be used for ICU studies. And remember, you cannot use organ failure scores if you're studying mild to moderate severity of disease. So our take-home message, MELD score uses easily available variables. It's able to classify severity of disease, mild, moderate, and severe. It's prognostic across all stages of disease. It's useful in determining treatment benefit. And it's applicable to other etiologies of liver disease. And so perhaps MELD score currently may be our best bet. Thank you.